We're going to talk about personalized therapy for acute myeloid leukemia, and it shares a lot of the abnormalities that you heard about already for myelodysplastic syndrome, and genetic therapy is very common for the treatment of solid tumors, including diseases like malignant melanoma, kidney cancer, colon cancer, and lung cancer. And I think the question is, okay, is this feasible for a disease like acute myeloid leukemia? You heard that CML has one abnormality, and we have pills for it. Can we develop pills for AML? And I think when we first started thinking about this 9 or 10 years ago, we were struck by the number of mutations that we see in patients with AML. It's fewer than most solid tumors, but there are still, on average, 13 mutations that we deal with, and they come in 9 different categories here. So it was pretty daunting, and I think 10, 15 years ago, you would hear experts talk about, we'll never be able to do this for acute myeloid leukemia. So in chronic myeloid leukemia, there's one target. It's called the BCR-ABL abnormality. And in acute myeloid leukemia, we deal with a lot of different targets, 9 different categories. And these are the most common abnormalities here, the IDH1 and 2, which you heard about already for MDS, WT1, MLL, etc. And so we're going to talk a little bit about these. And what we do is we group these into major categories here. And the wheel spins here, and there are approximately 6 areas that we've focused on over the last 10 to 15 years, trying to come up with genetic therapies for patients with acute myeloid leukemia, recognizing that in many cases it would be only a small subgroup of patients. But this is now ingrained into everything that we do when we see a patient with a diagnosis of acute myeloid leukemia. And really, to see a patient at the time of first diagnosis, it's absolutely necessary that you not only make the diagnosis and do chromosome analysis, which helps determine a prognosis, but that you do the molecular analyses for a bunch of genetic things for which we might have therapy for, including KIT, FLT3, NPM1, CEBPA, and other mutations. And these have been chosen because they are validated commercial assays, and we can measure them, and some of them may be important prognostically, and then again, some of them may be therapeutically of value. And we're going to talk about the therapeutic values for most of these patients. So what we do now is divide prognosis of acute myeloid leukemia based on chromosomal abnormalities, which we've been doing for the last 20 to 25 years, and now have integrated into that some genetic abnormalities. And then at the end of the session today, Dr. Hagen is going to talk to you about the different prognostic groups, and I'm not going to really focus on that at this point in time, but more talk about genetic therapies that we can use to treat patients. Now, when we first started looking at the genetic mutations in acute myeloid leukemia, obviously the pie graph here is pretty daunting, but actually there are major categories, one of them being FLT3, one of them being MLL, one of them being NPM1. And so we initially focused on the major categories and determined, can we develop genetic therapies for some of these abnormalities, because some of these are definitely very prognostically important for our patients. So for CML, we have one major mutation, so we have effective, if not curative, therapy with oral agents for the BCR-ABL mutation, Gleevec, dasatinib, nilotinib. But for AML, it's unlikely that any one targeted agent will ever cure a single patient, due to most patients having multiple mutations, and then again, between patients, we see so many different abnormalities. But the number of potentially actionable mutations is so large that no one therapy will be effective for any more than 30% of any group of AML patients. And here I show you this mess, if you will, which basically connects the notion that if you have one abnormality, you're going to actually have a very large proportion of patients another abnormality. So patients with FLT3 ITD mutations very frequently have NPM1 abnormalities, DMT3A as well. So all these can be mixed up together, and if you have a treatment for the FLT3 that doesn't take into consideration some of these other genes, you may not have an effective therapy, as we heard about this morning in the MDS talk. So the strategy of targeted therapy for AML is, I'm going to talk about two things. Number one, targeted antibodies, and you just heard about antibody therapy for non-Hodgkin's lymphoma, and we now have an FDA-approved agent over the last 6 months for treatment of AML, and I'll go over that data, and then targeted genetic therapy. So the Mylotarg is the FDA approved for CD33 positive, which is seen in approximately 90% of patients with AML, and midostaurin, which is the first genetic therapy approved for AML, which happens to be an effective agent against the FLT3 ITD mutation. So we're going to talk about these as well as some of the less common ones that may be also effective. So CD33 is a marker on the top of AML blasts. It's actually on many of our primitive myeloid cells in our bone marrow that eventually produce neutrophils and monocytes. It's also present on most AML blasts, but it's not on the stem cells. And attaching a chemotherapy drug to an antibody, as we heard about this morning, for several conditions, including multiple myeloma, permits more targeted damage to acute myeloid blasts. And this drug, gentusumab ozogamicin, basically attaches itself to the surface of the myeloid cell. And what it does is it carries a chemotherapy drug, calicheamicin, which actually then is absorbed into the cell and leads to the cell dose. So it's a target to the AML cells, and then the chemotherapy gets inside the cells. Mylotarg actually is not a new drug. It's actually approved under accelerated approval from the FDA in May 2000 as monotherapy for relapsed elderly patients with acute myeloid leukemia. But the FDA, when they approve some of these drugs, they rush them to market, if you will, because they want to help patients with the disease, required a confirmatory trial, and that was performed in the United States under the Southwest Oncology Group banner. And I'll show you the data on that. That failed to confirm the clinical benefit of Mylotarg. So by convention, the FDA and the drug company took the drug off the market, largely because it didn't really help patients, they felt, but it also had some complications, including a rare condition called veno-occlusive disease of the liver. So Pfizer, which owned the drug, took the drug off the market in 2010. So here was the design of the SWOG study, in which patients received chemotherapy plus Mylotarg or chemotherapy alone at the time of diagnosis, and then consolidation got Mylotarg low dose as consolidation therapy or observation. And what they showed was that the complete remission rates were identical. The chance of going into remission were about 70%. And the percentage of patients, however, who died of complications because adding therapy to really toxic chemotherapy already did seem to increase the number of patients with complications that led to their death. And so the SWOG Data Safety Monitoring Committee recommended early closure of both the induction and post-consolidation randomization, and that's what led to the discontinuation of the sales of the drug. We do know that for patients with relapse disease, there was a lot of efficacy of this drug, and especially for elderly patients. However, our European colleagues rescued us, and if you will, with this drug. The way the drug was given in the United States was a big shot of the drug once. That led to the increased toxicity to the liver. And what they said was, why don't we give a little bit of the drug over a longer period of time? When we give chemotherapy for AML, we do usually give it over a week. So they lowered the dose and gave it 3 doses, and then gave it with the standard chemotherapy of 7+3, and then consolidation with Mylotarg, only 1 dose at the lower dose, and determine whether or not this would be of value. And as you can see here, what they found was that there are fewer people who relapsed who got the Mylotarg as compared to those that didn't get the Mylotarg. They subsequently additional studies in England, and what they did was a meta-analysis. And all in all, what this did was to lead to the notion that when we first started using this drug, we gave it wrong, but if you give it in a new way, a less toxic way, not only do you see less toxicity, but you see an improved response rate. So a dramatic and significantly meaningful improvement in survival that includes remissions and overall survival. So the greatest benefit, however, is in the favorable cytogenetic population. So again, the importance of doing chromosome analysis is there, and almost no benefit in the poor cytogenetic risk population. So you may find that if you're in a younger patient with a good risk cytogenetic abnormality, that your doctor is going to recommend not only standard chemotherapy, but low doses of Mylotarg to be given along with it, because the survival seems to be better. So targeted therapy with Mylotarg improves survival in favorable risk AML and is becoming more the standard. So let's now talk about the specific genetic therapy, which is designed to get inside the cell, not just the surface, which is the Mylotarg dig inside the cell, and to try to treat the bad genes. So how or why do we select patients for this therapy? Well, we start with the prognostically bad genes, the genes that are associated with an inferior survival, and then start with the most common ones. And the most common ones that we started with were FLT3 and IDH1 and 2, which you already heard about in the MDS talk. So FLT3 is a chromosomal abnormality. It's a gene found on chromosome 13. It's a proto-oncogene, which makes it into a cancer-causing gene. It encodes for a surfeit receptor that's normally seen on bone marrow stem cells, and it's a critical factor for the proliferation and survival of stem cells. So this is something that is normally seen in our stem cells, but it can and frequently does in about 30-40% of adults mutate. And what happens, because this causes a proliferation of cells, when it mutates, things kind of grow out of control. The cells proliferate more rapidly, and they survive a lot better than normal cells. And again, very frequently when we see a patient with this, they have very, very high white counts when they're diagnosed. So there are two major mutations that occurs, the ITD, which is the more common, which is again seen in the majority of patients. It's mostly in normal chromosome patients. It has an unfavorable prognosis in which patients have a higher rate of relapse and decreased disease-free and overall survival. Transplant can overcome some of this, but it's not as complete as we'd like to see it. The second one is a point mutation in the tyrosine kinase domain, or the TKD. It's only 7%, and it's actually not that unfavorable. So when you see a patient with FLT3, you got to make sure you know which one you're talking about. So the treatment of patients currently is with chemotherapy and a drug called midostaurin, which is FDA approved. It's a multi-targeted kinase. And on the basis of preclinical studies, showed synergy between chemotherapy and this agent. And basically, early studies showed that it could be administered safely with chemotherapy and after consolidation therapy. And as you can see here in a large study that was presented literally a few months ago, was associated with an improvement in progression-free survival and overall survival. So for the first time in many, many years, a targeted agent that actually caused more patients to live longer. So more survived the therapy that received the midostaurin, and now the drug is FDA approved for this indication. So when we see a patient who's newly diagnosed with AML, we check for FLT3 abnormalities, and if there's an abnormality, we now have an agent that we add to the chemotherapy, and this therapy helps survival in both in the transplant and the non-transplant patients. We still feel, however, that the transplant is the optimal way to treat these patients in remission, so this drug is not a substitute for transplant. There are other agents now that are in the pipeline that are being developed. One of them is a drug called sorafenib. This actually is a drug that's been around 15 to 20 years for patients with kidney cancer. It's also a FLT3 inhibitor, and we can sometimes add this to patients who have relapsed FLT3 positive AML who are not candidates for a clinical trial. And the other three drugs are still in clinical testing. Some of them are very, very potent, and perhaps even more potent than midostaurin and sorafenib. So for all clinical trials that are ongoing, the results are very encouraging based on recent updates. I'm going to go through a couple of these newer agents that, again, are not FDA approved currently. The drug was tested in a patient who had refractory AML. So patients had FLT3 positive AML, they relapsed, and they were given just this one pill to treat their disease. And of the 249 patients, 40% had a response to treatment, including 90% of the response was a complete disappearance of this leukemia. 10% had a partial remission. So 36% of the patients just given a pill for refractory leukemia had a complete remission. So a very, very striking result, and again, validated the fact that the inhibitor was effective for this type of leukemia. And the second drug is quizartinib, and this is a drug that just last week announced the pivotal trial results showing that they met their primary endpoint of prolonging overall survival compared to chemotherapy for patients with relapsed refractory disease. And we're going to hear about the details probably in a couple of weeks at the annual cancer meetings. And finally, the third drug is crenolimab, and this is being tested. And in combination with regular chemotherapy like the midostaurin, 18 of the 24 in complete remission. At a follow-up in the first study, 83% of patients had received minimal residual disease, that MRD that we've been talking about all morning, and 80% of those had not relapsed. The first drug that we're talked about here is sorafenib. That also is commercially available and we can use it. It's a very effective drug for FLT3 positive patients. However, it only lasts a couple months, so you do need other therapy. For the other drugs, for refractory patients, it does work anywhere from 2 to 4 months, and the strategy now is to actually add it to chemotherapy, and then there's a national trial that's just getting underway in which patients who are going on to bone marrow transplant for FLT3 positive disease are randomized between one of these agents and conventional observation with a placebo drug to see if the additional drug will improve their survivability. The second one we heard about are IDH mutations, and this is something that is also being considered for MDS. As you can see here, AG221 is a first-in-class oral selective inhibitor of IDH2 enzymes. A phase 1/2 trial did show that patients with refractory AML had a response rate of 40% with a remission lasting 5.8 months. Overall survival was 9.3 months and 19.7 months. So again, for patients who have refractory disease with this mutation, 19.7 months if you responded to this agent. The FDA has now approved this drug for use in patients, and we do use this for patients who had failed initial therapy. So IDH2 mutated AML, we're going to talk about novel targeted hypomethylating agents and finish up with BCL2 targeted agents. We heard about this drug, SGI-110. It's a new agent that's a prodrug of decitabine and is being tested for MDS. The first study, however, was in 103 patients with relapsed refractory AML. 23% of the patients entered a complete remission. Median survival was 6 months, and 19% of the patients were alive at 2 years. So again, you have end-stage leukemia, you take this novel therapy, and 20% of the patients are alive at 2 years. For refractory patients, this is very equivalent to getting a bone marrow transplant. A second trial of untreated patients showed a remission rate of approximately 57% and a median survival of 10.5 months. This is not FDA approved, but again, is very promising and potentially useful in maintaining remissions as well. Novel hypomethylating agents we talked about already in the MDS talk is a modification of DNA by adding a methyl group. Too much methylation leads to growth of cells, so we want to reduce the amount of methylation that occurs in some of these leukemia cells. And the main methylating agents that we use to treat AML are also the same drugs we use to treat MDS, and they're azacitidine and decitabine. Finally, I want to finish up with BCL2 mutations. Now, if you remember that curve, that graph with all those lines going back and forth, the BCL2 is really not something seen in acute myeloid leukemia. BCL2 is overexpressed in B-cell lymphomas, as you heard from Dr. Venugopal, and CLL. When overexpressed cells do not grow faster, they just die slower. They just last a lot longer, and it's harder to kill them. The slowing of death also occurs in AML. That's part of the reason that patients go into remission, because they grow slower, they die slower. BCL2, however, is not usually overexpressed in AML. But we have found that inhibiting the normal functions of BCL2 in the lab did promote their killing. Venetoclax, a drug you heard about just in the last talk, which is FDA-approved BCL2 inhibitor, did show a modest effect when it was used in a single-agent trial for refractory leukemia, a complete remission rate of 19%. So here's a targeted therapy for a non-overexpressed gene, but in the laboratory, based on some very striking data, used as a single agent, 20% of patients went into a complete remission. So in combination now with a hypomethylating agent, and specifically low-dose azacitidine, you can see here on the left side, we're seeing very dramatic responses. Here's an overall survival. The follow-up is somewhat striking here in these patients. If you just give the hypomethylating agent and look at the same time period, just with the hypomethylating agent, less than 10% of the patients are alive. But here, it's approximately 50%. Average survival, 17 months. Average survival, 7 months. This is now undergoing phase 3 testing, and one of the large review editorials just a few months ago said that phase 3 testing shows a clinical benefit of venetoclax combined with low-dose hypomethylating agents. Then this combination would not only redefine therapeutic approaches to AML in older patients unfit for intensive chemotherapy, because these are pills, the venetoclax, but would also likely prompt expanded testing of the venetoclax combination in younger patients with curative intent. So very striking results, very promising. I think all of us who study patients with AML and think that we are following the science of genetic abnormalities, when we first heard that venetoclax might be of value in the patients, we shook our heads because, again, BCL2 is not overexpressed, and yet look at these dramatic results. So for the personalized therapy for AML is possible, just like it is for other solid tumors. Newer targeted agents just in the last 12 months are showing an improvement in survival for AML for the first time in 40 years. We are seeing more patients live longer. New FDA approvals of these agents are finally here. It is critical now to know not only the chromosome, but also the genetic makeup of every patient's AML to design the best therapy, and this really needs to be done at the time of diagnosis. Like other cancers, the first treatment remains the best opportunity for the best outcome. While I gave you a lot of results in patients who had failed upfront therapy, we really haven't gotten to the point where we use these drugs as part of initial therapy. So there's a lot of promise coming down the line over the next 3 or 4 years. Knowing as much about the leukemia when first diagnosed will truly provide the best chance for cure. And I think all of us who treat patients with AML are really excited about the possibility in the future, especially because this is a disease with an average age of 68, and the number of patients with AML literally is doubling in a period of approximately 30 to 40 years, starting in the year 2000. So I'll stop there and answer any questions that you might have about this, and then we'll go on to the next one. Sir. Okay, so hemochromatosis is a genetic disease. You're born with it. It's a familial condition in which your body absorbs and holds on to iron, so you have too much iron in your liver. MDS is a disease of the bone marrow, so it's totally unrelated. However, patients with MDS can get therapeutic or iatrogenic, we call it iatrogenic because physicians cause it, or treatment cause it. We can give you, with each unit of blood, a substantial amount of iron. So with the transfusions you get, you end up with hemosiderosis, not hemochromatosis, but hemosiderosis, in which the liver fills up with iron as well. So it's a transfusion-related condition. Both of those are treated best by minimizing the amount of oral iron you're taking, so a vitamin without iron. And there are drugs now that help leach the iron out of your body. The only way we get rid of iron in our body is by bleeding, but some of these new drugs can actually leach the drug out of the body Not completely, but they are sometimes effective, especially if you can reduce the number of transfusions. As you heard from Dr. Khan, one of the biggest emphasis in MDS is to reduce the amount of transfusions that we're giving to patients. And iron overload, as she showed you, can actually lead to significant morbidities, and sometimes patients do die of iron overload. What's the difference between lymphoma and CLL? They're both B-cell disorders. They are not related to acute leukemia, but in fact, there's a form of CLL called SLL, small lymphocytic lymphoma. It has to do with the degree of differentiation of B cells as to where the abnormality occurs. So very primitive B cell abnormalities are acute leukemias that the kids get, and at the end of the B cell spectrum is multiple myeloma, which is a B cell as well. And somewhere along the pathway you see CLL, non-Hodgkin's lymphoma, follicular lymphoma, mantle cell lymphoma, and it's just in the spectrum of abnormalities of B cells. Absolutely. It's a question of are they commercially available? So the venetoclax is commercially available, and it's a question of getting permission from your insurance company to do that. So we always pre-certify patients for can we give them the venetoclax? Can we give them the midostaurin, etc. Midostaurin is not approved for relapse or refractory disease. It may have some benefits. Sorafenib, which is a drug for kidney cancer, does have activity, as we talked about, for FLT3-ITD, and we have to get permission from that. Medicare is a little bit different, and they don't pre-approve anything for Medicare. They just tell you no when you've done it, or they'll pay it, etc. So sometimes there is sufficient data in the literature that you can con them into doing it or appeal a denial, but those are sometimes challenges for patients.